Thank you, Mr. President, and thank you for AGA for the nice invitation and good organization and the huge number. Mike, okay. My talk about the هي دي مش شغالة. لا دي شغالة لا دي شغالة. Okay. About knee dislocation. About the definition. The definition of knee dislocation remained unclear and not agreed upon for a quite long period. But nowadays, the law in the knee dislocation or multi-ligament injury or MILKI term is used with less ambiguity if two or more of the four main ligaments are injured. And although we are talking about a wide spectrum of injury, but still there is low incidence of this spectrum that may drop till 0.02 to 0.2% of the whole injuries. And due to this low incidence, you will always find, if you dig into the reports and meta-analysis and the studies, you will always find vague phrases like rarity, paucity, scarcity, or ambiguity to describe the data of this spectrum. And this makes the multi-ligament injury a real land of debate. And in this review presentation, it's a review presentation. I will highlight the most important debates and what are the final agreements. First, the sequence of in the ER, the sequence. Don't forget that this MILKI patient, multi-ligament knee patient, could be part of polytrauma. So make attention to the ABC priorities, the airway, breathing, and the circulation, and the whole limb neurovascular integrity. Then do your reduction, bracing, and even you can put an external fixator, then plan your surgery to bone and ligament. Again, keep in mind that vascular injury and ischemia could happen in acute setting or even up to 3 weeks with minimal intimal injury and the insidious occurrence of intramural thrombus or intra-arterial thrombus. And the second point to keep in mind that this patient is more liable to compartmental syndrome, either after injury or even after the surgery. And if the compartmental pressure rise up more than 30 millimeter mercury, this may warrant immediate fasciotomy. Next step, do or conserve. Do a surgery or conserve the patient. Formerly, serial casting with variable degrees of flexion and extension was used for multiple ligament knee injury. But nowadays, there is robust reviews and robust data that ensure that the surgical intervention is more superior and have more results, good results, as compared to the conservative. As regards the stability, the range of motion, even the range of motion is better. and the functional outcome and the return to sport. So, do it in acute or delayed setting. This is the next debate. Let's agree on the 3 weeks interval. This critical period of 3 weeks during which the tissues still have it could be easily identifiable with sufficient integrity and no retraction. So if you try to repair it, the suture will go into the tissues easily without cutting through a friable tissue. Beyond this, you may face difficulty in repairing a friable tissue. Of course, acute surgery is better than the delayed one, with better scores again and return to sport as compared to the delayed surgery. The fourth debate, do all at once or staged surgery? Although conventional trends tend to do staged surgery for fear of the post-operative stiffness, but nowadays or recent trends reveal that if you do all at once surgery in acute stage, either repair or reconstruction, this will end up with better results if you reach a stable knee and proceed to accelerated rehabilitation. And this study by Laprade warrant this data. He did a single stage acute multiligament injury all at once with accelerated rehabilitation. The second debate, repair or reconstruct. Actually, all ligaments does not behave in the same manner. For example, posteromedial corner and medial collateral tends to heal on its own. So most of the surgeon wait for 3 or 4 weeks in brace protected with bearing. Unless there is some situation like incarcerated ligament or grade 3 completely off ligament, or if the residual instability remain, this may warrant an anatomical reconstruction by Laprade, as Dr. Tahsin said. But in contrary, if you look at the posterolateral corner, it's completely the opposite. I mean that it does not tend to heal. So most of the data encourage the reconstruction. Despite some surgeons who prefer the repair plus augmentation, but repair alone, forget it. What technique? If you are doing an ACL surgery combined, just ACL surgery combined with the posterolateral cordon, Larsen technique is more than sufficient. But if you are doing PCL surgery or the knee, the degree of the instability is great, like KD4 or something. So the anatomical reconstruction of Laprade is mandatory. Finally, the ACL and PCL the ACL and PCL ligaments. I know that, and all may agree that reconstruction is the gold standard, but as Dr. Omar Bat said, that the acute avulsions may justify the repair plus or minus internal bracing. What about the last debate, which is very important? What to do first? There is no solid data that justify the best sequence of graft tensioning. And traditional consensus agrees about PCL to be done first and tensioned first, followed by the ACL reconstruction, posterolateral corner and posteromedial corner to end with. But recent studies support tensioning both cruciate with fixation of the ACL first. Kim and colleague challenged a dogma of comparing one group of patients who tensioned the PCL and fixed the PCL first, and the other group who have both cruciate tensioning and ACL first fixation. And interestingly, they found that both stress radiographs and clinical outcomes to be better with the ACL first group. And they advocated a very nice sign to ensure that the reduction is concentric, is the notch, or the lateral femoral condyle notch engagement into the anterior horn of the lateral meniscus as a sign of concentric reduction while ACL fixation. And they ran through this sequence of events in their operation. They did the PCL tibia tunnel first, then PCL femoral tunnel first, second, followed by passing the PCL graft and fixing the femoral side, then doing the ACL tunnels, fixing the femoral side again, then tensioning both cruciate together and did the ACL fixation first, then go to the PCL, posterolateral corner, and finally the posteromedial corner. My take-home message is, if you want to have excellent results or best results with your milky patient, try to stick to early, one-stage surgery, repair if feasible, and start with cruciate. Thank you.